Well, it is straight up noon, everybody, and so I think we'll begin. Welcome, and thank you all for joining us today at today's Donor Circle of Excellence presentation on new strategies in dementia care. This is a topic of interest to many of us, as evidenced by our great turnout, and they keep coming in. For those of you I haven't met, I'm Molly Stearns, Chief Development Officer here at Overlake. And on behalf of our entire foundation team, welcome. Our Circle of Excellence programs are just one small way we can thank you, all of our donors, for the support you give us. We could not do it without you. And all, our special brand of world-class compassionate care takes resources, and these days those resources are harder and harder to come by in this industry, and your support matters more than ever, so thank you. Before I turn it over to our CEO, Mike Marsh, who will offer a few remarks of his own and then introduce our speakers, I want to run through some of our usual virtual meeting reminders. Most of you could do this in your sleep by now, but just as a reminder, we have you all on mute at the moment. There'll be plenty of time for questions at the end. If you have a question during the program, put it in the chat, and we will make sure that it gets dealt with. And so thank you for that. If there are any technical questions, please call the Foundation office, 425-688-5525, and we will work with you. So Mike, I'm going to now turn it over to you, and thank you for being here today and for helping us kick this off.
Okay, thanks, Molly, and welcome everyone. I looked at the attendance list. I think most of you know me, but as Molly said, I have the great privilege of serving as the president and CEO of Overlake Medical Center and Clinics. I've now been with Overlake for a little over 9 years, and it's been really one of the greatest privileges and pleasures of my entire career. To our Circle of Excellence members, I want to express my deep appreciation to your support and to your advocacy that you provide to this great medical center. Without you, we couldn't have grown into the world-class medical facility that we are today, or continue to offer the extraordinary care we provide we will provide into the future. You know, we do have beautiful facilities, as you can see by the shot behind me of our new tower, and life-changing technology, but what really matters are our best-of-class staff and physicians. These tireless healthcare heroes are not just dedicated to caring for our patients, but also for each other. And I believe that this is one of the things that makes Overlake so unique when compared to many other organizations, both locally and across the country. And, you know, when we look at surveys, employee engagement surveys, we consistently outperform all the benchmarks, but in particular, we always exceed by a mile questions related to Overlake's culture and our ability to work together as a team. And in healthcare, that's really important because it does require a team to provide the level of care that's necessary for the patients that we're serving in the 21st century. We continue to grow. We're no longer just Bellevue's hospital or the Eastside's hospital. We're rapidly becoming a destination medical center for the Northwest. Nearly 25% of our patients now come from outside of the East Side, so the West Side, Central Washington, the Kitsap Peninsula, Everett, Olympia, Tacoma, Oregon, Idaho. They're coming from all over. In some of our service lines, it's actually up to 50% of our patients are coming from outside of the East Side. So we really are becoming a destination facility. And in fact, that part of today's presentation has some relationship to that. Our Circle of Excellence presentation today will focus, as you know, on our growing neurosciences service line. As some of you, maybe many of you know, a few years ago, we formed something called the Eastside Neuroscience Institute in partnership with Evergreen Health. And we did this in order to combine resources between our two organizations to provide the most highly specialized neurological care in the entire region. Our focus on new strategies of dementia care, as you'll hear today, is but one of many examples of how we are continuing to lead the way to create better care for people suffering from these conditions. So ourselves and Evergreen really felt that we could be better together in helping to advance the neurosciences service line and forming the Eastside Neuroscience Institute. So today you will hear from two Overlake neurologists, Dr. Laudann Taravati and Dr. Sarah Koch. Doctors Taravati and Koch are two examples of the incredible talent we continue to recruit into our region. They will share how the Eastside Neurosciences Institute is improving ways for us to understand, diagnose, and treat Alzheimer's and other neurodegenerative diseases. Dr. Taravati joined Overlake as a neurologist in 2022. She completed her residency at the University of Washington and in 2020, and she is certified both in psychiatry and neurology. Dr. Koch also joined Overlake in 2022 and as a neurologist, and she completed her residency also at the University of Washington. I'm seeing a pattern here. And she is also certified board certified in psychiatry and neurology, both two terrific new talents to our community. So with that, I will turn it over to Dr. Taravati and Dr. Koch. And I do want to remind you that to submit questions in the chat. And in addition to our physicians, I will also be available for questions too. If I'm not sure I'll be able to answer many neurology questions, but maybe if you have questions around the larger healthcare ecosystem or Overlake in general, I'll stay in the bullpen and run out on the field if you have a question for me. So thank you very much again. And with that, I will turn it over to Dr. Taravati and Dr. Koch.
All right, so to do the typical check, we just shared our screen. We want to make sure that everybody can see the slide deck that should be up now.
Yep, you're good.
Perfect. So I am Dr. Sarah Koch.
I'm Dr. Laudann Taravati.
And how we're going to go about this presentation is just to give a little background information on the diagnosis and management of Alzheimer's disease and honestly background information on a lot of general kind of dementias. And so I'm going to get started with that. Potentially, if the slide will change. So I first want to give an overview of what exactly is dementia and what constitutes it. So dementia is not a formal diagnosis in and of itself. Instead, dementia is kind of an umbrella term that encompasses a lot of different disease processes that affect memory and cognition. There is a lot of different types of memory that we have, such as visual spatial memory, our language memory, and of course our learning and recall. And so dementia is having difficulties with one or more areas of these different types of memory. Specifically, it has to be a decline from a previous level of functioning, and it has to be severe enough to impact daily living and independence. And we'll get into that shortly, kind of what constitutes not involving daily living versus what does. There's a few different types of dementia. There's primary dementia. This is dementia that does not come on as a result of other disease processes in the body. The most common and the one that we're going to spend a lot of our energy on diagnosis and treatment of today is the one that most people have heard of, which is Alzheimer's dementia. Its most prominent feature is a loss of short-term memory and being able to recall and do day-to-day tasks. But you can also see there are other types of dementia I won't go into as much, but there is vascular dementia related to damages that come on in the brain. There's Lewy body dementia. This is one of the other more common forms of it, which has a lot of features of Alzheimer's dementia, but we actually see changes in walking, balance. People tend to have more psychiatric symptoms with this type of dementia. And then there's frontotemporal dementia. This is certainly less common. It's been getting a lot of media attention recently due to some celebrities have come out with it. And this has different subtypes, ones that specifically affect language and behavior. And you can see that there's secondary dementia. Secondary dementia is, again, a change in cognition that affects function, but instead of being related to a primary disease like you saw on the last slide, it can come from other neurologic diseases, damages, injuries, toxicities, and I won't go into every single one, but you'll see some common things on there. A lot of people know Parkinson's disease, and that can come along with memory loss and difficulty functioning later in the disease process. Traumatic brain injuries, toxicities to the brain, various vitamin deficiencies and other disorders can also still cause a dementia process. And then I want to just touch a little bit on something that we call mild cognitive impairment. So mild cognitive impairment is a process that does not yet meet criteria for dementia. It's when we see that there are memory changes that exceed normal age-related changes, but the patient is still able to go about their day-to-day activities. They have not yet lost any independence, have not lost any particular safety aspects. Some people have mild cognitive impairment due to the secondary causes that I mentioned on the last slide, and we try to identify those and treat them if possible. But sometimes mild cognitive impairment is, in fact, an early stage of dementia. And normally when people are diagnosed with this, we do like to continue to see them in further visits because about 10 to 15% per year do progress on to dementia. And I'm not going to, again, go into too much on the photo in this slide, but I think it is a good example of minor difficulties that aren't yet impacting people's day-to-day abilities to go through, and they're good examples of things that we screen for when patients do come in to get evaluation for memory loss in our clinic. There's also a lot of things that mimic dementia that we screen for during our visits. The first one is something called polypharmacy, which is essentially patients being on multiple medications. The older we get, the more susceptible we are to polypharmacy, which is basically having a higher risk of side effects to medications, and especially medications that are used in combination together. Even if the medications are not known to have particular interactions with one another, we can still have an effect on our mentation and cognition with multiple medications. Another thing we see a lot is poor sleep, and specifically sleep apnea, where people have brief pauses in their breathing during sleep, leading to overall poor quality sleep, which can also impact our memory and thinking. Hearing loss is involved too. One of my favorite lines to use in clinic is, "You can't remember what you don't hear." So I recommend that most of my patients with even mild hearing changes get testing for their hearing to see if they need any hearing aids. Then sometimes as we age, we're more susceptible to having illnesses and infections that can affect our thinking. And then we also screen for mood disorders because it's been shown that patients who have untreated depression and anxiety can also have impaired thinking and memory. So once we kind of establish that somebody is having difficulty in their day-to-day life, and we're not quite sure if it's normal aging, if it's this mild cognitive impairment or this dementia, we kind of go into how we end up diagnosing patients with this. First off, there's some signs and symptoms for patients and family members to watch out for. Again, not all of these are 100% diagnostic of dementia, but might be examples of things that should prompt patients or families to say, hey, maybe we should get this looked at and make sure everything is or is not okay. I took this list from a wonderful organization that I think Laudann's going to touch on in just during her part of the presentation, which is the Washington State Dementia Action Collaborative. They have a lot of really good resources for patients and families about these different stages of memory changes, what to expect, and I just felt that this was a very good and comprehensive list. And then most of the time, people are first seen by their primary care providers and get some basic screening evaluation. And those doctors can choose to send the patient to neurology or not, or sometimes if the concern is high enough, people can bypass that and come see us in our clinic. And here's a kind of list of things to expect during the visit, things that we do to help understand what's going on. Dementia is a clinical diagnosis, meaning that we don't have to do brain imaging, blood tests, things like that. We tend to because it's recommended to rule out other causes. But at the end of the day, kind of the information given to us by patients and family is the most valuable. And I think I stress to all people that it's really important when patients come to us for a visit about their memory that they have another person that's close with them come to the visit, because sometimes patients don't know what they don't know, and that additional family history is really important for us. So some things we do is questions regarding the symptoms you've seen on other slides, asking questions about day-to-day life and function. We're going to be trying to review those mimics that I talked about, see what kind of medications that could be eventually potentially affecting their mentation. And sometimes if we feel like we need it, we can do brief memory testing. And the picture on the side of the slide is just an example of one of the brief memory testing that we do, but we have a handful of them that we can employ if needed. There is additional testing, as I mentioned, if something is not obviously clear, or we just want to do our due diligence and rule out any alternative causes. The first is basic blood work to look for those various things that I mentioned could be reversible, like hormone problems, vitamin deficiencies, those kinds of things. And then two common imaging modalities used to take a look at the brain itself is an MRI and a PET scan. I believe in our clinic we favor MRI over PET scan due to ease of access, this volumetric testing, which I'll touch on in a second. It's a bit more sensitive for overall structural changes in the brain. But then there's a PET scan, which is a way that we look at how glucose is being used in the brain to see if there are areas that are less active. The volumetric analysis is something you see on the side. Again, I won't go too in depth into it, but basically it's software that helps us measure out different parts of the brain and help us see if we see any patterns of degeneration that seem atypical for age-matched individuals. And then there's even more specialized testing. Again, won't go too much in depth because these are certainly things that we tend not to do unless there are things that aren't lining up, things that don't make sense, or we just need a little bit more clarification. But that includes genetic testing, which is not routinely done. Maybe sometimes if there's a strong family history, or again, if it's a little unclear what kind of things we're dealing with. And then also there are biomarkers. Biomarkers is a measurable substance. It can be in the blood, it can be in the fluid that sits around the brain and spinal cord. And biomarker testing is fairly new in the world of cognitive neurology. We look for particular proteins that can be seen in Alzheimer's dementia or similar dementias. And we look for patterns on whether which one's high, which one's low. And again, not something that is required for a diagnosis, but if there's some things that aren't lining up, we can certainly look into it if needed. I'm going to pass over to Dr. Taravati now.
Okay, so now I'm going to talk a little bit about Alzheimer's specifically. So say you've gone through this comprehensive diagnostic evaluation with your neurologist, primary care provider, and you've arrived at a diagnosis of Alzheimer's disease. Well, what do we do about this? Well, there's a few different categories we often want to think about. So it's not just start a medicine and then we'll see you back in a few months. It's often kind of a multimodal approach involving lifestyle changes, medications, doing home safety kind of planning, making sure that we're working on getting advanced care planning kind of things in place, and then thinking ahead to any possible future caregiving needs. So first, starting with the lifestyle changes, we go through this with everybody with any kind of memory change, even mild cognitive impairment. We have the best data that tells us that Mediterranean style diet is the most protective of brain health over time, specifically most protective of developing additional vascular or blood vessel injury related insults, which can sometimes worsen memory problems in light of those that have Alzheimer's disease. We also recommend exercise 4 or 5 days a week, at least 30 minutes at a time. Similarly, this helps with protecting brain health over time. Ideally no smoking, and limiting alcohol, ideally no more than a drink a day for women or a couple of drinks per day for men. And folks with memory problems, I even cut those limits in half, just to really limit that potential effect on cognition. Making sure that you're following very closely with primary care to monitor other conditions that many folks have in older age when they develop Alzheimer's. These are things like high blood pressure, diabetes, and high cholesterol. All of these things can, again, contribute to a little blood vessel injury in the brain, which can accumulate over time and contribute to thinking and cognitive problems. And then the last, and this can be somewhat surprising for some folks, we always recommend social interaction. So it turns out that folks that are quite socially isolated, it tends to worsen a lot of thinking, memory, dementia type symptoms. We had a lot of problems with this at the beginning of the COVID pandemic with everybody isolating. It was quite tough for a lot of folks. But now with things opening back up, we really encourage folks to stay active, meeting with a once a week gym exercise group or meeting with some folks to go for a walk around the block are great ways to help incorporate that. And beyond lifestyle changes, we do have a few medications that can be helpful. We're going to start with some of the ones that are more tried and true that have been around for some time. And then we'll get into some of the newer medical therapies you may have heard about on the news that have been kind of making some waves, go over some of the pros and cons and recent data for that. But starting with the current recommendations, so there are these medicines that help block, that help increase acetylcholine levels. So acetylcholine is a neurotransmitter in the brain that's thought to be deficient in those that have Alzheimer's disease. So there are some medicines listed here that can help increase acetylcholine levels. These medications can provide some modest benefit. Unfortunately, these medicines, we don't really have anything that can reverse or even stop the progression of Alzheimer's disease. But the idea is that these medicines can help slow that memory loss progression down over time. All medications, you do run the risk of side effect, and this one is no different. The main side effects can be upset stomach, like nausea or diarrhea. So often this is one of the first line medicines that we start. Next are these medicines. It's called memantine or Namenda. This is kind of a neuroprotective type medication that we use as our next agent. So this medication has both more modest benefit, and generally with those that have a more moderate to severe case of Alzheimer's, so when their disease has progressed more. They've done some studies looking at it when taking this medication earlier in the course of the disease, and it doesn't really seem to change the outcome much, except for expose you to medicine side effect. So for that reason, it's generally started later on as a second medication. And same deal, it unfortunately does not reverse or stop this Alzheimer's progression, but it can help slow it down. This medicine also can have some infrequent side effects like confusion, dizziness, and headache, but generally tends to be pretty well tolerated. And then these new medications that have been making the news lately, these are the monoclonal antibodies. They are very new. There's a third one that's still having some data being released. These are not yet commercially available in the Puget Sound region. I'm not sure of any places around here that are offering these infusions. The way these medications work is that they bind to a protein called beta amyloid. So it's thought that in Alzheimer's that this beta amyloid protein aggregates and clumps together and causes a bit of injury to the neurons. So the theory behind developing these medicines is, well, if we can have these medicines bind to the beta amyloid and clear it, then hopefully it can even slow down or potentially reverse the process. So there's a few of these that have come out. There's aducanumab or Aduhelm, lecanemab or Leqembi. And then the one that's currently kind of finishing up its, all the studies and is being investigated right now is donanemab. Currently, the American Academy of Neurology consensus statement about these medications, there's a lot going on here. They recommend that there is some risk. We'll talk about the risk in just a bit. That you have to confirm that there is indeed some beta amyloid present in the brain. Guarantee that before you start the treatment. Part of that is because Alzheimer's has many mimics, as Dr. Koch mentioned. Vascular dementia, for example, can look pretty similar. And the way this is done is not always part of the traditional diagnostic evaluation. You have to do this either by a spinal tap, lumbar puncture, or by an amyloid PET scan, which many times is not really covered by insurance and can cost upwards of several $1,000s. So that already is a little bit of a barrier to entry, to seeing if you're even eligible to start these medications. So far, in terms of the effectiveness of these medicines, I will say it's been controversial because it has not been very robust. When aducanumab, the first of these medicines came out, it was, everyone was really excited. It seemed like it was reducing the decline or even improving some of the memory testing scores that folks were having. But on further analysis, they evaluated folks with something called the clinical dementia rating score, which is a score that looks at all the different levels of assistance that you require with your help with day-to-day activities, your memory function. So more of a clinically relevant scale. And it turns out that folks that were getting this aducanumab infusion had basically no change in this clinical dementia rating score compared to those that were given placebo. This next medicine, lecanemab, the second one that's been developed, they noticed a 0.5 point difference, 0.48 point difference in this clinical dementia rating score. So technically, it is a reduction in the decline in terms of level of assistance in day-to-day activity. But this is a score out of 18. Is a 0.5 point score out of 18 very significant? I'm not sure. This third medication, donanemab, the data is still in the works. So far, the pharmaceutical company Eli Lilly that is running this program, they have sent out some preliminary results suggesting that there's a change in the clinical dementia rating scores compared to placebo. But they haven't released any raw data or strict numbers. It's just been percentages. So we're still waiting on that data to get a better idea of what's going on there. The other concern is that there is a pretty significant cons list for this monoclonal antibody group of medication. So again, it's unclear whether this benefit actually translates into any meaningful clinical benefit in real life. The other concern is that these medications have been noted to increase the risk of brain swelling and bleeding. And some of those symptoms can include headaches, confusion, dizziness, and nausea. And this has been noted in anywhere from 20 to 40% of the folks taking these medications. Because these are pretty serious, neuroanatomical consequences, swelling and bleeding, it does require that you have pretty frequent surveillance with brain MRI while you undergo these treatments. And so do we have currently the imaging infrastructure to provide this degree of surveillance, MRIs for everybody with Alzheimer's every 3 months, and all the additional diagnostic facilities? I'm not sure. The big other thing to keep in mind is the cost of this is not insignificant. So the cost of the infusions for about a year is about $50,000. If you include the surveillance monitoring studies and things like that, we're probably looking around $75,000 per year. There was one study that estimated that lecanemab and all the ancillary services involved with getting that on board, if it's offered to all folks with Alzheimer's, could cost Medicare up to an additional $5 billion per year. We also don't really have an endpoint for this. The trials so far have just measured endpoints around 76, 78 weeks, maybe a year and a half or so. But we don't have any data to know, is this something that should be continued lifelong? Is this something that's only continued to, safe to take for a year and a half? That much is unknown. And then the last thing, there was this analysis of a bunch of different Medicare beneficiaries that had Alzheimer's disease. And it turns out that most of them, vast majority, 86% of them had some kind of other medical condition, like stroke or heart attack history. They were on blood thinners, they had kidney disease, they were older than 85. All of these conditions, these folks were excluded from any of these trials, from this first aducanumab trial. So we don't actually know for sure if this medicine is safe to use in folks with these conditions. And most folks with Alzheimer's will have at least some degree of this. So I think the data, because of this, I would say most neurologists are wary of this category of medicines, and we're really just waiting for more information to help guide whether this is actually safe and effective to use. So that was all medications. Beyond the medication standpoint, we really want to be mindful about home safety. So the Alzheimer's Association has this really helpful home safety checklist where you can go through, where folks, when they are in the earlier or mid or late stages of dementia, they may not have the insight to know about how to handle hazardous materials, or maybe leave the stove on by accident and things like that. And so these checklists can kind of help with removing trip hazards, avoiding hazardous options, keeping alcohol or dangerous things locked away as much as possible. And this applies to all the other rooms in the house as well. Advanced care planning. So this is really helpful. Ideally, you want to be thinking about, who do you want as your medical and legal decision maker if and when it gets to the point where you are no longer capable of making those decisions for yourself. You would want to do this as soon as possible, before the time you would really need to do it. And that really helps avoid a lot of conflict and stress for patients and families. This group that's Dr. Koch mentioned, the Dementia Action Collaborative, if you go to their website, memorylossinfo.org, they have a really comprehensive list with a bunch of different things, including this legal planning toolkit, which includes things like documents for power of attorney forms, healthcare directives, wills, all kinds of things. So I really encourage folks to take a look at that sooner rather than later, to get that paperwork handled before the time they would really need it. And then caregiving options. So when folks are coming to see us right away, if they're having kind of more mild form of dementia and they're just having a little trouble managing their finances, that's one thing, but you want to prepare ahead for the times where folks may need more caregiving support, even with day-to-day type functions, like having a home caregiver come in, or knowing about assisted living type facility options. The same Dementia Action Collaborative has a pamphlet on there called the Dementia Roadmap, which is a very helpful guide for kind of going through the different stages of dementia, what to expect, all the caregiving resources for all the various stages. It also includes some links to the Family Caregiver Support Program, different support groups, and ways to kind of manage behavioral tips and ways to kind of help manage communication. And so we did receive a few questions in advance, which we have listed here, which we'll go through in a bit, and then we can open up for questions from the rest of the group. One of the first ones was, what can we do to prevent dementia? Really the biggest thing you can do to prevent dementia is focusing on lifestyle changes. So things like the Mediterranean diet, exercise, avoiding excess tobacco and alcohol, and then closely managing those risk factors that can injure the blood vessels in the brain, like high blood pressure, diabetes, high cholesterol. Beyond that, unfortunately, we don't really have any medicines that can, completely prevent this from happening. And it is an inevitability for some folks. And I know sometimes it's built into genetics. Other times it comes along with some of the lifestyle issues. The best we have to prevent is really more the lifestyle changes. There are some questions about, what do you do if somebody has inherited this ApoE4 variant? So there are a lot of genetic tests out there that can sometimes tell you if you have this ApoE4 gene. If you have 1 or 2 copies of this gene, it means that you have a slightly increased risk of eventually going on to develop Alzheimer's. This does not mean that it's going to definitively predict that you will develop Alzheimer's. We actually have no way of predicting if anyone will develop Alzheimer's in their lifetime. It just means that you may be slightly increased risk of developing it. So at the end of the day, we recommend, we really only have the lifestyle changes to focus on. And for that reason, that's part of also why we don't really routinely offer this ApoE4 genetic testing, because we don't really have any way of predicting yes or no if you'll develop Alzheimer's, and it wouldn't really change our management recommendations. How and when should you have a diagnosis? Well, I'd say sooner rather than later is helpful. Often folks start with seeing a primary care provider. Many times they start with running some basic labs, and they can get you referred to a neurologist as soon as you notice trouble with memory difficulties. Identifying it earlier in the course of the disease can give us time to start medication sooner rather than later, work on the lifestyle progressions, and then prepare much more in advance for progression. Is there any change in routine or activities expected? Well, staying physically active is always important. Depending on the stage of Alzheimer's, some folks would need to make accommodations to different routines. So for example, having some alternatives to somebody driving on their own if they're no longer safe to drive, having someone else drive them, or getting some help to do day-to-day activities like chores. Generally, establishing a routine can be very helpful. And this is especially helpful to prevent episodes of confusion called delirium, which can happen on top of dementia. Which treatments are available if someone's diagnosed with Alzheimer's, and especially in the early stages. Like I mentioned before, the first medications we often start are the ones that work on acetylcholine to slow this progression, and then we really work on lifestyle changes as well. And then how do we recognize dementia, especially in folks that we don't necessarily see every day? Say you've got a neighbor that you see every once in a while, and maybe they live alone. The biggest thing is to watch for a change in memory or change in personality. So sometimes folks will often ask the same question or say the same thing within a conversation. If normally they're kind of bright and cheery, but they seem much more withdrawn, that's something worth knowing about. And then make sure to ask whether folks are having any trouble with doing tasks at home. A lot of times folks may not be open about that, but when you ask them directly, they can say, well, I found I've been having some trouble with managing medications. I sometimes get mixed up with doing that. So that's something worth asking about anyway. And then any other questions otherwise?
I have to tell you, you guys, you are awesome presenters, and you are helping with my moderating role by already going to those questions with prepared answers. That's great. You win. We've never had presenters do such a great job, but now there is time for other questions, so thank you. Mm-hmm. What else do you guys want to know, people on the call? And Mike is here too if you want general questions about the hospital or our commitments to these various service lines. Wow. I think the silence is more related to the fact that you guys did such a wonderful job covering everything.
That's
Then
great.
yes, thank you so much. All right. With that, then, we're going to thank you both, Dr. Taravati and Dr. Koch, for this incredible presentation. I've learned a lot, and I'm sure others on the call would say the same thing. We will be following up with everybody with a survey to see what other topics we can offer you that would be of interest. Our job is, and our goal is to keep you informed and in areas of work that we do here at Overlake. And so please let us know what other topics would be interesting to you, and we'll work on making that happen. We'll also be sending an email to you later today to get any feedback on how this presentation went, how easy it was for you to tune in and to hear and get your questions answered. So look for that as well. We'll also
Hi,
oh, yes, sorry.
Sorry, this is Sandra. I actually do have a question. Can you hear me
good,
okay?
Sandra. Yes, go for it.
So early diagnosis is the best, is what I heard from the presentation. Thank you, by the way, it was an excellent presentation. If somebody has a history, a family history, like father, 2 uncles, and mother had Alzheimer's, so early diagnosis would be better for that person, I'm assuming. It doesn't guarantee, I mean, I guess genetically that means a person has had it in their system. It may not be fully vetted in their case, but it's good to have early diagnosis. If they also have heart issues, sleep apnea, don't really stick to a Mediterranean diet, then, you know, those are the first steps, I'm assuming, as well. So meeting with your primary care physician, who is at Overlake, and then talking to a neurologist. I think those were the steps that you guys talked about. Or is there are there some other specialists at Overlake that you know, would be the best to see?
Yeah, generally starting with a primary care physician is helpful. Many times they'll start with a little bit of memory screening during that visit, or if there's enough memory concerns, they have a pretty low threshold to get you referred to see us in neurology. The specialists that have the most experience with managing, diagnosing, managing dementia would be neurology and I think geriatrics in primary care. And then, and you're absolutely right, for folks that have a kind of a compelling family history of Alzheimer's. Again, it's never something where we can guarantee it's something you develop over time, but it is something that we want to keep an eye out just as a possibility. And working our best to kind of help protect your brain as much as possible. You do mention the sleep apnea. Thank you for bringing that up. We do often want to screen for sleep issues because many times if folks have very poor non-restorative sleep and they're snoring a lot, many times undiagnosed and untreated sleep apnea can cause a lot of daytime fatigue, a lot of brain fog, trouble with thinking. And can even either kind of be a dementia mimic or be contributing to dementia getting worse. So that's always something worth screening for as well.
Okay. And pain also. I mean, so this is a real case. There's somebody I know who's got these symptoms, but the also has lots of pain. So that's a problem with sleeping. So even if you have sleep apnea, you try to use your CPAP, you wake up, and then it's not as comfortable. So trying to figure that all out. So that's why primary care physician. Got it.
Yeah. And sleep especially can be challenging because, a lot of folks, they have insomnia. Maybe that's not related to sleep apnea. And that sometimes they take sleep aid medicines, which can then really impact your cognition. But insomnia itself can also impact your cognitions. There are a few kind of cognitive safe medications that are worth discussing with either your primary care or sleep specialist.
Got it. Okay, thank you.
Good. I think I see a fatalistic comment from the Colettes in the chat. Yeah. It is let's keep to our Mediterranean diets and exercise and hope for the best, I guess, is the answer.
Yeah.
Sorry, we're looking for the comments
right there.
It's on the bottom.
Yeah.
We didn't want to hear that. We wanted to hear.
If we we had a medicine that we could give you, and if we would guarantee that you would never develop Alzheimer's or other dementia, that's like Nobel Prize material.
Wouldn't that be, that would
be, you know,
yeah.
you would all be the first to know.
Yeah.
But yeah, unfortunately, so far with the data that we have, the information resources that we have, these are the main things we can recommend.
Yeah, it's funny. Yes. But I've got faith in the fact that you guys are on it and you'll be keeping us informed. And as you learn more, as this field opens up, we'll all benefit from what you are learning. So thank you again, both of you, for presenting. This was very, very interesting. And we will also, in addition to the recording of this presentation, as Katie has put in the chat, we also will send a link to the deck, because it's a fascinating deck, and I think it's something that we can share with our friends and family members and others who couldn't join us today. So thanks again for that. All right.
I do have one more question. Is
Okay.
this information shared with the primary care physicians, like the concierge care that's part of Overlake?
Do you mean this slide deck specifically, or like whenever we see a patient as part of the evaluation?
I know the general information that's available to the doctors that are on site at Overlake. I mean, do they have access to some tools to, you know, in addition to doing the 3 tests, like, you know, I'm going to give you a color and a place and whatever and a number. Remember that. I mean, in addition to that, is there some other, because you said contact the primary care physician. So if you contact the PCP, what tools do they have? I mean, do they have tools? I don't need to know what, but do they have tools through Overlake, through their, you know, the Overlake internal system to assist with this?
Mike, do you want to speak to how we keep our medical staff stays current with different?
That's it.
Yeah.
Yeah. Go back on mute.
There we go. Sorry, my mic wasn't coming off mute. You know, there's a variety of functions for stay. I think that the short answer is we do our level best. I think we could do better. You know, we have a growing medical staff. We have a mixed medical staff. Some of our medical staff are employed physicians, like Dr. Koch and Dr. Taravati. Others are independent physicians. But we generally do look for lunch and learns that we do routinely across a variety of specialties to give physicians tools who may have patients who are suffering from specialized challenges that maybe isn't more routine in their practice. We also, within Overlake clinics, which is our employed platform, do have something called our combined leadership team that talks about means by which to onboard tools and resources to physicians. That's the area that I think that we could do a better job of. But in the main, I think we do a reasonably good job of distributing information across our physician platform to help non-specialists or primary care physicians to have access to some of the fundamental tools that they need to help in the early intervention.
Great. Thank you.
Yeah, I want to stress that primary care has been really wonderful for us to interface with. And most, almost all primary care, if not all primary care, gets training when they're becoming doctors on how to screen for memory problems. And sure, they might not know the absolute nuances of, mimics, medications, things like that, but they certainly have a good sense of when somebody should be pushed on to specialized care. And we're always here to help and support them in that. And they do have a few screening memory tests that they use as thresholds to chat with us, but it's been really easy to interface with them and have their patients come over to us for evaluations and opinions. And so they seem, very good on the general kind of screening and understanding, and we're here to support them with the nuances that come with it.
Great, thank you. All right, and Rob has put in the chat a call out to our Overlake Senior Care Clinic, which is also a group of docs, geriatricians, who, as you alluded to earlier, I think Dr. Koch, as you started, that is a specialty that helps very much in treating at the primary care level these patients. So, all right, Well, thank you, everybody, and we'll give you 10 minutes back in your afternoon, and just appreciate so much you joining with us, and definitely appreciate all your support for programs like you just heard about and everything else that we do here at Overlake to maintain the health of our community. So thanks very much, and we'll see you next time.
Thank you.
Thank you for having us.
Bye.
Thank you.